Welcome to the Healthy Brain Toolbox. I'm Dr. Ken Charlin, neurologist, speaker, author, and host for this show. In each episode, I interview influential people whose work impacts how we live and how we think. My guests are leaders in the health and fitness industry, physicians, scientists, authors, and public servants. Here you'll find conversations that break down barriers, expand your horizons, and give you the tools you need to protect your health and nourish your aging brain. So today I am thrilled to welcome Jennifer Chester, APRN, MSCN, to the show. Jennifer is a seasoned neurology nurse practitioner with over 30 years of experience in healthcare and more than a decade specializing in the diagnosis and management of neurological conditions, including migraine, multiple sclerosis, epilepsy, stroke, and dementia. She began her career with a BSN from Creighton University, followed by an MSN and a family nurse practitioner from Binghamton University. Over the years, she's held clinical leadership roles across the HCA healthcare system, most recently at College Park Neurology, where she was known for her compassionate, evidence-based care. Jennifer has now transitioned into a medical science liaison role at Octave Bioscience, and that's what we're going to talk a lot about today. This is an innovative biotech firm focused on advancing neurodegenerative disease management through precision data science, and in particular, the MS disease activity test. In this capacity, she bridges the gap between clinical practice and neuroanalytical research, expanding her impact from patient care to the forefront of medical innovation in neurodegenerative diseases. So please join me in welcoming Jennifer Chester. So great to have you.
Thank you. I appreciate being here.
Time for a brief message from one of our sponsors. Do you ever find yourself struggling with brain fog, memory lapses, or that mid-afternoon crash? Maybe it's difficulty focusing, mental fatigue, or even the early signs of cognitive decline. These can all be signals that your brain isn't getting the fuel it needs. That's why I recommend Keto 5, a breakthrough in targeted brain nutrition. Their supplements, Exo Genius and Exo Ultra, are scientifically designed to support focus, memory, and long-term brain health. Exo Genius delivers a rapid boost in ketone levels, giving your brain clean, sustained energy for hours, without sugar, without carbs, without the crash. Exo Ultra goes deeper, providing a pure beta hydroxybutyrate formula to help you achieve effective ketosis for sharper focus and stronger mental clarity. But it's more than energy. Research shows that ketones can reduce neuroinflammation, protect brain cells, and support mitochondrial health, key defenses against conditions like Alzheimer's and Parkinson's disease. Imagine clear thinking, better memory, and a brain that thrives, not just today, but for years to come. Fuel your mind, protect your future. Visit drcharlins.com/collections/keto5, KETO5, to learn more and get started today. Jennifer, just before we dive into things, tell me a little bit about your journey into neurology and what some of your discoveries along the way were that ultimately led you to be interested in the work being done at Octave.
I've had a toe in neurology since my first nursing job out of college in the 90s. I got a job in the ortho neurotrauma unit, and neuro stuck. Everybody didn't want neuro, and I found it very interesting. And it's amazing how far it's come since the early 90s when I first graduated. And personally, I was touched by it as well. I had various neurologic conditions within my families, from stroke to Parkinson's and dementia. And I could relate to many of the things that my patients were dealing with.
That's wonderful.
Yeah. MS came my way after I got my nurse practitioner, because we typically didn't see MS patients in the hospital unless they were there thinking it was a stroke and it was actually MS. But for me, I started working with a general neurology practice that saw mostly stroke. And the doctor I worked with said, "Why don't you see the MS patients?" Because they are more time consuming. It's definitely a very holistic approach. You're treating more than just one thing. You're treating that whole patient from head to toe. And so being the nurse practitioner in the practice, I could spend a little more time with the patients. It piqued my interest, and I did a little fellowship training at UT Southwestern. It was just a short few days, but it just immersed myself in it. Came back and I'm like, "I'm ready to go." And from there, I got my certification in MS nursing, and then eventually switched over to working for an MS center full time.
That's great. And again, as we get into the details of Octave, the MS disease activity test, I wonder if you yourself had, because I will say just personally, I had an aha moment with this particular test. It really changed the game for me as an MS neurologist. And I'm just curious if you ever had the chance to use the test before working with Octave as an MSL, and how your experience as a clinician was shaped by the information gained from the test.
Oh, absolutely. I was first introduced to Octave and the MS disease activity test in 2023. So I was still in practice and we started using it on as many patients as we could. And I definitely had my aha moment, which I'll definitely be happy to share that case with you. But I was already entertaining the idea of switching over to industry. And honestly, when I met the folks from Octave and saw what they were doing, saw the cool science behind it, I immediately was interested in this would be the company I'd want to work for and not just big pharma.
That's wonderful. So let's give folks, I guess let's do two things. I want to make sure that listeners have a little bit of idea of what MS is, like the elevator speech, the three sentences. It's not going to be super detailed. Not
Right.
everybody listening to this podcast is going to have MS, but in general, I think you probably agree that we think of MS by and large as a neuroimmune disease. Whether it's truly autoimmune is more of an intellectual argument, but certainly our own immune cells do play a role in this disease. There are cells that largely belong in the peripheral bloodstream that make their way across the blood brain barrier and ultimately participate in the inflammatory response in the brain. We think too that there are changes, of course, that happen within the brain itself that are part of that overall milieu. So it's probably not just the peripheral immune system, but ultimately people with MS develop these classic plaques that are seen on MRI, some of which enhance with contrast, meaning there's been disruption of the blood-brain barrier. They're acutely inflammatory. And then sometimes they do resolve, but many times, unfortunately, they leave a footprint of a past injury, if you will. And then, of course, in some cases, if the degree of inflammation and ultimately neurodegeneration is enough, they actually leave in their wake a hole in the brain. And so there's very much loss of neurons. The flip side of MS is neurodegeneration. And we can think of not just the attacks that relapse and remit, but ultimately a progression of disease in which there's acquired increasing disability over time, largely measured by changes in gait, but other aspects, of course, as well. And there may be a more insidious kind of progressive pattern of the disease without discrete attacks, but just getting worse and worse over time. When I first started, we may be about the same age. When I was resident at University of Virginia in 93, the first disease modifying therapy came out, was called beta seron. And it's not a highly effective drug, and it's probably not prescribed a whole lot anymore. I still have one or two patients using it, but they're legacy patients because they've been on it and it worked for them and they were happy with it. It did have some side effects, but we've lost a lot of people over the years to multiple sclerosis. And so when the drug came out, it was under such demand. There was actually a lottery, at least at UVA, to get
Yep.
the drug. Following the development of this interferon-based drug, we had interferon beta 1A, beta 1B, or the other way around, really. Beta 1B is beta seron and beta 1A was Avonex, and then Copaxone. We called them the ABC drugs. And we lived with those for a very long time until we started to see more effective drugs sometime in the early 2000s, initially with natalizumab, and then eventually with a drug called fingolimod, and then it's taken off from there. And we do have some very effective treatments. Probably the most exciting treatments right now that are available commercially are the B cell depletion drugs like ocrelizumab and ofatumumab and ublituximab, if I said that. And at any rate, and then some of the, although not approved, the highly efficacious hematopoietic stem cell treatments that are available to a limited extent. But at any rate, you and I have seen this over the years, and it's really changed a lot. People are now HIV, people live with HIV. They don't die as much from AIDS anymore. I was very much in the midst of the AIDS epidemic and training and saw some things that I wish I never saw, some horrible things. But people don't, of course, there are people who are more severely affected, but by and large, we're in a much better place. And then we have historically tracked our patients using MRI. And I don't know, I'd love to hear how you tell the story about MRI. What I've said, especially since this test came into my world, is, and I'm talking about the Octave test, that getting an annual MRI to track our patients is kind of like installing a fire alarm system in your home and then asking the technician, how do I know if it works? And then the technician says to you, if your house burns to the ground and the alarm didn't go off, then it didn't work. Because really, we get these MRIs once a year, typically, right?
Mhm.
And we look for new lesions. We look for disease activity that has already happened. In other words, that damage to the brain has already happened to
Right.
make our clinical decisions. And punchline, at least for me, is what's amazing about this test is not only is it blood-based, so it's a fraction of the cost, and we'll get into that, but it is not just a snapshot as what is happening now, but it's predictive. And so we can potentially catch that fire while there's just a little smoke and a flame in the kitchen because you forgot there was something in the oven, rather than the whole house burning down. So it's an opportunity for folks to really avoid the disability associated with MS.
Yeah.
I hope that's all good.
That's great.
My enthusiasm for this test. So let's go back. Okay, so it's a blood test, right?
Yes.
Walk folks through this because it's critical and it's detailed, it's complex, but you guys do a great job of making it easy at the same time.
So it is a blood test. It is a simple blood test, one little vial of blood. But what we're looking at is blood biomarkers, which are actually proteins that are in the blood. And so through this, we see different effects of the disease through these proteins. So if you think of MS and the way you described it and the way that it works on the body, it affects the immune system. So there's immunomodulation. Then there's neuroinflammation. Then there's myelin biology because the myelin is what's being attacked. And then there's neuroaxonal integrity, right? So that's where the damage is happening. So those are the four pathways that make up the different biomarkers that we're testing. And together, we get 4 different pathway scores based on the 18 proteins that are being tested. And then from there, we give 1 disease activity score from 1 to 10. And 1 is low disease activity, which is where we want everybody to be. And 10 is high disease activity.
Yes. And you divide it into 3 groups where you can be 1 to 4, up to 4, correct?
Yeah. And then 4.5 to 7.5, I believe. And then, or 7 and 7.5 to 10 is high.
So I get this test and I'm curious. And again, I I could be wrong. So we've got the expert here. Right now, to make the diagnosis of MS in the most mainstream, traditionally accepted, validated, I suppose, way at the moment is to use what's called the 2017 revised McDonald criteria, although as there's the revisions that are the 2025 that are in the works. I don't think it's been certainly presented, but I don't think it's been rubber stamped yet as, yes, we're doing this. But the McDonald criteria does not say if you have an abnormal MS disease activity test, you have MS. In other words, the MS disease activity test is not technically right now considered a diagnostic test.
It is not diagnostic. I think with the new McDonald criteria, which really focuses on early diagnosis, so some of those patients who typically may not have fallen into the right category may now fall into that category. And you could use this then, do we go ahead and start treating early or not? Because they meet all the criteria. Where maybe some of those patients years ago may have waited to be treated.
That's right. So you would typically, I would, and I know you, and as a clinician, we've taken a medical history, you performed a physical exam. Ultimately, to arrive at the diagnosis of MS today, we can't make a diagnosis of MS without performing an MRI because we want to at least demonstrate the lesions or plaques separated by space. This is more of a technical point. Of course, that there are ways to demonstrate that they have appeared at different time frames if that is not apparent on the MRI, although I understand some of that is changing a little bit with the new criteria. There is a lot of interest in what is called clinically isolated syndrome. So the person that has their first attack, they haven't had the repeated attacks. We can't establish that space and time factor, only perhaps the space part, but we think it's probably MS. And then there's even what is called radiologically isolated syndrome, where maybe you were in a car accident and you had an MRI because somebody was worried about, did you have a brain injury? And somebody looks at the MRI and goes, I don't see any evidence of brain trauma, but does this person have MS because they have periventricular white matter or Dawson's fingers and so forth. And some of the other classic signs of MS that we see on MRI, but they've never actually experienced the symptoms. They never had optic neuritis or whatever manifestation of the disease. There is even discussion, of course, of premonitory or what is happening at the biological level before we start to see those lesions. And I think that even potentially is a place that the disease activity test could theoretically have a role. But I'm going back now. I'm going to make my diagnosis. I've got my MRI. I'm sitting down and having a serious conversation with the patient. And I'm going to probably want to order that MS disease activity test from the beginning, right? Once I know, yes, this is MS. Okay. So tell me, how would you see now we have all this data, right? Because I always tell my patients, look, tests are data. Tests are just, nobody is fixed with a test. It's just information. So let's talk a little bit about how the test then could be used in clinical practice. Why do it?
Yeah. So we're going to do it. That first patient, when they're first diagnosed, we really want to get that baseline of how active is their disease right now today. We're going to get that initial score before they even go on treatment. So let's say we've got our baseline score and then you've chosen the treatment they're going to go on. 6 months later, we recheck it. And that tells us, are we on the right medication? Has your disease activity score come down to a much safer level? And that's what we want. So say they went on Avonex, which we're not really using now as much, but that would be one where you wouldn't expect much of a drop in that disease activity score just because it's as efficacious. But today we have so many good medications, we can see that disease activity score come down quite a bit. But things happen. People need to switch treatments. They have side effects or breakthrough disease. So that would be another time you would retest. Say you're testing on a regular basis to make sure they're stable. You're going to test them again if they have any breakthrough disease activity or new symptoms to assess for relapse. After a switch, you're going to reassess them. And then through the years, checking it on a regular basis, just as you would with an MRI, it's still assessing their level of disease activity. Either you're visualizing it on an MRI or you're doing it in a blood test. Both would be still important. Then it comes to discontinuation, now because people are living longer with MS. When do we stop treatment? So that's a big question. So if they've been getting their baseline testing done and routine monitoring over the years and they've been stable and now maybe they're 65, 70 years old and doc, do I need to continue taking this? Let's see, your disease activity score has been maybe a 2 for 10 years and now maybe it's time to come off. You stop the treatment and you continue to monitor their disease activity. Or think about the treatments we have like cladribine, alemtuzumab, where you dose for 2 years and then you're done. And those patients ask, how are you going to know everything is okay? Now we have something else to do. We can watch your MRIs, which as it could be too late, disease happens, or we do an MS disease activity test, hoping to see that underlying activity even before the changes in the MRI.
Now it's time for a short commercial break. Imagine a future where brain health is not just managed but optimized, where the symptoms of Parkinson's, Alzheimer's, traumatic brain injury, stroke, depression, anxiety, and even long COVID can be addressed with cutting-edge technology. That future is here with the Neuronic Light and the Neuronic 1070 nanometer photobiomodulation helmets, a breakthrough in non-invasive brain therapy. Using near-infrared light, these devices penetrate deep into brain tissue, stimulating cellular repair, reducing inflammation, and enhancing mitochondrial function. Research suggests this technology can even enhance cognitive performance in healthy individuals, all without drugs or invasive procedures. The Neuronic 1070 helmet takes it further, offering 4 customizable operating quadrants, ideal for tailoring programs in conditions like stroke or traumatic brain injury. And with every 1070 helmet, you'll receive a free 30-minute brain health consultation to help you maximize the benefits. Whether you want to support memory, restore energy, or take proactive control of your brain health, Neuronic technology could be the game changer you've been waiting for. Unlock the power of light, heal, restore, thrive. Learn more at neuronic.online. And when you make that investment, be sure to use the code Charlin100 with a capital S to get your $100 discount and let Neuronic know where you heard about this valuable technology. I have a slide deck that you guys gave to me a while ago, so I don't know if it's been updated, a PowerPoint type presentation, unbranded. And it has referenced one study that you guys did where you compared people in the low and moderate disease group to people in the high disease group. And you were looking at the likelihood of new enhancing lesions.
Yeah.
And if you were in low and moderate versus high, if you were in the high, you were 23 times more likely to have new
So
gadolinium enhancing lesions.
21 times more likely if you're in the high range. If you're in the moderate to high range, it's 5 times more likely to develop a new lesion.
Where I'm also going with this is, and I alluded to it in my analogy about the fire in the house and the alarm system, that it doesn't also necessarily mean that you do have a new lesion, but you're at great risk for having a new lesion.
Exactly. Now, if we want to share can I share my aha moment?
Yeah.
Where and I actually shared this case with Octave when I was in practice, and now that I'm here, I get to continue sharing this case. But this was a patient who was treated with cladribine. So she was one that we were monitoring after she completed her 2 years of medication. And she was 3 years out, and we did her MSDA, which was her first test, so her baseline test. And she was a 5. And she's actually a nurse, and I don't like that score. And I'm like, I don't like it either, but this was your first test. So I don't know what this means. It's in the middle. I don't love it. I'd rather you be low. But she had no new symptoms. She felt fine. I said, we'll retest you. So that was in 2023. And then in 2024, we tested her. She came in for a usual visit, no new symptoms, was feeling great, and her score was a 7. So she
Mm.
increased by 2 points, which we would consider significant. And I said, I know you don't have any new symptoms, but we need to make a plan here because I don't know that this is working for you because you increased by 2 points. So we had the discussion about treatment and maybe we should switch or continue the same one. And I said, let's get your MRI done. Sent her for an MRI, 2 new lesions. And she had no new symptoms.
Mm.
So I wouldn't have, and it was a little early yet. She wasn't quite due for MRI. So I wouldn't have sent her except for that change in her score. And then I called her, of course, and she knows when I call the day after her MRI, that's never a good thing. And so we had that conversation of what we're going to do next. And we switched her DMT. That's what she felt most comfortable doing. But that was that first moment of, because of this test, it actually made a difference in how I was treating my patient.
So true. I have had similar, not exactly the same, some scenarios that I think is worth sharing with folks listening because I think everybody's going to identify with one of these cases. I've been very interested in MS remission and what the data has told us. And of course, we've had to rely largely on clinical data up until recently with the MS disease activity test. Not that it's necessarily become the gold standard to determine if somebody's in remission, but it is certainly an exceedingly helpful tool. So I have had patients actually who have moved. I live in Southwest Missouri, where a lot of people choose to retire because we have the Ozark Mountains and Table Rock Lake, and real estate is inexpensive. And people move from California, where they're paying over $1 million for a little two bathroom, 3 bedroom ranch on a 1,600 square footprint or whatever. And then they come to our area and they can buy a veritable mansion for the same amount of money. So anyway, the point is somebody moves here. It's unfortunately difficult to get into neurologists all around the country. It's often a long wait and they don't always plan the best, but they come here. They're not on their medicine. Maybe it took them a while to get around to getting an appointment. They're I'm going to make up a number, 63 years old, haven't been on drug for 2 years. Maybe they were on ocrelizumab is the case that comes to mind. And I said, have you had anything that you would consider relapse? No. Have you had any disability progression, any changes that are sustained? No. Exam looks good. And I do the MS, maybe we get an MRI. Of course, they're going to have lesions. They may not be enhancing, but that doesn't necessarily move the mark for me. So I do an MS disease activity test, and they have a disease activity score of maybe 2 or 1.5. And I say, you're 63, you've gone 2 years, you've had no relapses, you've had no progression, you have no enhancing lesions on your MRI, and you have low disease activity. I think you are in remission. If you are comfortable with this idea, I would recommend that we not initiate disease modifying therapy, but we track your disease activity test maybe semi-annually for a couple of years. And if you still are low disease activity, we're done. Your MS is done. It's over.
Yeah.
So very good one. Another patient I've seen is a gentleman who came in from another clinic, progressive MS, for some reason was on Gilenya, which is not, or fingolimod, not indicated for progressive MS. But at any rate, visits 5 minutes with a neurologist. Your MRI looks okay, but I think I'm getting worse. I think I'm getting worse. Oh, your MRI looks fine. So he did this for about 7 years, at least. Comes in and sees me. Said, let's do an MS disease activity test. Score is 7.5.
Wow.
He was almost in tears, not just because, that someone was listening
It's
to him,
validating. Yeah.
validating. So we put him in one of our clinical trials on a BTK inhibitor. So he's doing just fine. But there are these cases, and I do find that sometimes even following the standards of the McDonald criteria from a diagnostic perspective, sometimes you're like, I'm just not, maybe not. And off label, quote unquote, I have used the disease activity test to add to the database, as it were, to make a decision. Is this definitely MS? I would wonder, and this would be a question for you or your associates and more on the science side of the company is, could this test be have higher disease activity in conditions that are not MS?
The test is validated just for patients with MS, but each individual biomarker can have fluctuations in disease states. So,
Right.
yeah,
And the two big ones are there are 18 separate biomarkers, and again, divided into roughly four categories. They are distinct categories, but you do this lovely job on the report of have this Venn diagram that shows how some of the biomarkers fall into more than one category, but they do include the neurofilament light chain and glial fibrillary acidic protein, which are two measures that have been used for many years in clinical research and only in the last year and a half became commercially available. So you can go to LabCorp Quest and have that drawn. And in fact, within about a month or two before I started ordering the Octave test, I did order a few GFAP and NFL tests, but in the end, I was like, why am I doing this? Because I'll get those two biomarkers and 16 more. But though, especially like NFL is fairly non-specific. It's just a marker of neurodegeneration, and
correct.
GFAP can be predictive in that manner as well as a predictor of disability in MS. But when I've put all of this stuff together globally or in a gestalt manner, I wonder whether there would really be a way to have a false positive, meaning a high disease activity score in somebody who didn't have MS at all. With all of the biomarkers combined, it'd probably be unlikely.
It's unlikely. There are those occasional cases where you head scratchers where you're like, you were really stable and your score is higher, but did they have other comorbidities? Yes. They think going on that you knew probably were skewing those numbers, but that
Right.
is rare.
Yeah, and to be clear, Octave is not promoting this test for other diseases, and it really is a tool for establishing a baseline and tracking over time. And we should probably talk a little bit about how often. But I do want to share one more case that I think is really important to MS patients listening to this. And I will say up front, I don't especially love the term, but I'll say I didn't make it up. And that is the pseudo relapse, right? And that basically means someone who has developed acute MS like symptoms, neurological symptoms. We have a case of this very recently of a gentleman with progressive MS who is largely in a wheelchair, a lot of lower extremity spasticity, had been making some very positive progress with physical therapy, doing some walking, and then had a major relapse where he basically couldn't use his lower extremities. And I ordered an MS disease activity test on him. And by the way, this was the third time, because we do it serially again, that I had done this. And not only was he low disease activity, but it was his lowest score that he had ever
Yeah.
gotten. It was something like 1.5 overall. So I said, I'm not questioning that you're having changes, but I'm not so sure this is due to some
Relapse.
acute change in your MS.
Yeah, we saw that too. And we'd go so far, we do the clinical exam, send them for an MRI, and we're like, everything looks the same. But now we can add in the MSDA to be that little tiebreaker of is something really happening or not? Because maybe we're catching it before the MRI changes are actually happening and it is creeping up, or maybe it's stable and there's something else causing those changes.
Yeah, hugely helpful. Let's talk a little bit about how often one might have this test done. And you could couch it in everybody is unique and different and consult with your doctor and all those sort of default things. And of course, Octave is not going to, you as a representative of Octave, not going to make a specific recommendation. But in general, what is your personal clinical experience? What are you generally seeing? How often should someone with MS consider having the blood test done?
I would say I cover half the country in my role. So I talk to a lot of clinicians who use this test. And I would say, in general, about every 6 months is pretty standard for most places.
I agree. In my experience, I have done it every 3 months in a few patients here and there. But I will also add that when my patients are on the B cell depleters, ocrelizumab and Kesimpta and Ocrevus, primarily Briumvi as well, the new kid on the block,
Yeah.
but certainly has a place in the toolbox. But at any rate, I have found that in general, for relapsing remitting MS, these drugs are so incredibly effective. I just say it shuts the disease activity down. I very rarely see a score above 1.5 or 2, very rarely. So as long as, they're doing fine, I have backed it off to annual when they're on those drugs.
Would make sense. Yeah.
Let's take a short commercial break. Looking for a natural boost to keep your brain sharp and your body energized? Discover Everyday Dose, the ultimate coffee alternative packed with lion's mane and chaga mushrooms, collagen, and L-theanine. This creamy blend supports focus, mental clarity, and overall wellness without the caffeine jitters. But coffee's not your only option. Everyday Dose also offers a premium ceremonial grade matcha sourced from Kagoshima, Japan, and infused with the same ingredients. Whether you go for the mushroom coffee or the matcha, Everyday Dose makes fueling your mind and body a breeze. Taken together, Everyday Dose has the potential to support memory, focus, sleep, nerve regeneration, gut health, immunity, and reduce inflammation, while the collagen gives you healthier skin, hair, nails, joints, and bones. If you'd like to give either of these great products a try, Everyday Dose will send you a free starter kit when you purchase a 30-day supply of coffee or matcha tea. Just use my link to save, www.everydaydose.com/healthybrain, and make Healthy Brain in all capitals. With Everyday Dose, you can drink smarter, feel better, and power through your day naturally. I love this stuff. I do. I'm gonna have some right now. Here's another scenario that I think is very interesting. Again, to review for folks, we get this global score, but then there are 4 subscores: neuroinflammation, immune modulation, myelin biology, and neuroaxonal integrity. The last one is of great interest to me because to me, it reflects the neurodegenerative component that is MS. We have to realize there's an inflammatory component, there's a degenerative component. In earlier stage disease, it tends to be more inflammatory, at least those who present with relapsing remitting MS. It can be an inflammatory progressive MS, but oftentimes it's a non-inflammatory progressive, meaning you're getting worse, but your MRI shows no new plaques, no new lesions. And I should add that we need to be, it's probably a separate conversation, but paying a lot more attention to brain volume and not just looking at plaques, because that's where a lot of the degeneration is going to happen.
Yeah.
But you can have a scenario where someone is doing worse, or you're just tracking them. You're maybe asking the question, are they on the right disease modifying therapy? And indeed, their inflammatory scores are low, but their neuroaxonal integrity score is high. And that seems to be another interesting pivot point for decision making.
Yeah, the test was only validated for activity, so new lesions, not progression. Progression is something we're very interested in, and that is the next panel that's in our pipeline. So we
Nice.
plan on having a disease progression panel at some point, and they're in the analytical phase of that right now, trying to identify all those different biomarkers that really indicate progression independent of the relapse activity.
That's very fair. And I would say, just on my end, speaking as an independent practitioner, if I see high degenerative scores, basically the neuroaxonal integrity, I'm going to say you may be on the wrong drug. Okay. Or we need to find some more solutions for you besides your medication that can ultimately address the degenerative component, because by and large, the disease modifying therapies are targeting the inflammatory component that is MS,
Correct.
by and large.
Yeah.
There's some data on brain atrophy, on reduced slowing brain atrophy over time, but these are secondary measures in most of the trials. Any thoughts just on the theoretical side? Again, it's not your test or your company, but this new emerging class of drugs is glutathione tyrosine kinase inhibitors. They are out there commercially, but not for MS right now. But we are going to see Sanofi Genzyme commercialize their BTK inhibitor for secondary progressive MS by the late fall, I think. That may be a class, and given its mechanism, that where there's a special place for those who have progressive disease.
Yeah, I think everybody's excited about the prospect of it.
It's an interesting situation because we've worked both with Genentech Roche as well as Sanofi Genzyme with fenebrutinib and tolebrutinib. And you probably know that several of the trials failed. And where they failed it, folks, is that with relapsing remitting MS, because we have so many treatments, you can no longer do a placebo controlled trial. So all these studies have what are called active controls, and right now, the main active control that's being used is a drug called Aubagio or teriflunomide. And so what ends up happening in these trials, that's considered a quote low efficacy drug. And in the clinical trial, the investigational drug, the BTK inhibitor, it wasn't that it wasn't effective, it just wasn't any more effective than Aubagio or teriflunomide. I think there were more or less economic and business decisions that said, look, if we can't be better than teriflunomide, it's not worth developing this drug further and promoting it. But that being said, given the mechanism where this class of drugs acts really within the central nervous system as opposed to the acting on the peripheral immune system, it may be that we now have a tool in our toolbox that targets those who then transition to more progressive MS. It is maybe especially an inside out disease, if you will, really active in the brain, less so in the periphery.
Right.
So very exciting. And I hope ultimately that Octave plays a critical role in helping us understand all that. So if I have MS and I have health insurance and I want to have this test done, the cost will obviously vary by people's insurance and their copays and their deductibles and all that kind of thing. But by and large, what are we looking at from the point of view of third-party payers?
We handle all the billing. So once your clinician has ordered the test, you go get it drawn. It gets sent to our lab in California to be run. And when that vial of blood is received, our billing department gets notified of the patient information, patient insurance. We will bill to all insurances to see if it could be covered. If it is not covered, then it's just reverted to a cash pay price through our Octave Cares program. And the most out of pocket would be $99.
Wow.
Many patients pay less than that, but that would be the max amount. And if it's covered by insurance, then it depends. What is the deductible? Do we need to work out a payment plan for that? If it's still too high, then we'll just withdraw that claim and do that cash pay price if no more than $99.
That is fantastic. And you're okay. In other words, sometimes the stipulations that come through the health insurance will only cover this a certain number of times per year. And not necessarily your test, but in general, I've seen that. And in that case, if they say, we're willing to cover it, but only twice a year, you guys can step in if need be that the patient needs an update.
Yeah, if they're going to cover it. We haven't yet. I think it's so new that we haven't been limited on how often yet, but I'm sure it's been.
Yes. And the other thing that I think is important, most people know they have a blood test. There's at least a couple major laboratories out there, Quest Diagnostics and LabCorp. This is not a Quest diagnostic test. There's not a Quest test code that you go to your Quest station and say, I want an Octave test. Octave Bioscience is its own company, is its own lab, so that practitioners interested in implementing this test in their office need to take certain steps to make that happen. And for those who are practitioners listening or watching, can you tell us what we need to do?
Basically, they would reach out to us and our neuroscience account executives would get that agreement, set up an account, and then work with whatever lab that you're in. If you have a lab there at your practice, some places use their infusion sites to draw, or there are some third-party labs that we contract with that would be willing to draw for us. And they get a kit, they package it up and send it to us.
Not too complicated to draw the blood and process it?
Nope. You draw it, you spin it, put it in the fridge, and it gets shipped on ice.
Fair enough. Ooh, I wanted to ask you a question. This has been, you were doing it in 2023. Where is Octave now? How geographically in terms of clinics across the United States? Are you in international markets? If somebody's in the UK or where?
We're just the United States, but we are approved now in all 50 states. New York was the last one to come on board because they have much stricter lab guidelines. So to get their approval was pretty major, and that spring. And so now we are in all 50 states.
Wonderful. So as long as you have a lab or access to a lab that's willing to work with you guys, set up an account, you send the kits, draw the blood. It's easy to process. I know what I wanted to say. So here's another thing that I just love about what Octave does, and this is really for practitioners. If I were to have just a generic blood test, doesn't matter, whatever you want, like a basic metabolic panel, and I'm gonna have that drawn maybe through Quest or LabCorp, no big deal. It's done billions of times every year. They get your name and your date of birth and your health insurance information, so you can bill your health insurance and whatever. But that's really, about it. What you guys do is completely different for practitioners, and I just love this.
Yeah.
So maybe you could share just in more detail all of the data that you're collecting to have this practitioner facing component as well, and really inform practitioners about what's going on with their MS patients in their practice.
Yeah, the order form itself, you can put more than just name and date of birth. You can actually put in the year they were diagnosed. You can put the reason why you're doing the test. Is this for a relapse, routine, initiation? What treatment are they currently on? So all that information gets put into our database, and we can pull that up and say, look at all your patients on B-cell depleters and see how they're doing. We can break it up by age group and see how your patients are doing. And then we also offer that report review with the clinicians as well. I get notified when my practitioners have one test, their first test, and then again after 5 tests. And then I always offer up that time to sit down and review the reports and see if they have any questions and discuss interesting cases and go from there.
That is so valuable. I mean, I have nothing against Quest, of course, but that would not happen with Quest Diagnostics. Like, it would not happen with LabCorp. But the fact that you can sit down and look at all your data and look at it at such high resolution and say, okay, my patient's on these meds, my patient on these meds. How do patients with MS do in my practice? Litmus test right there, because for practitioners interested in value-based care over fee-for-service, you have to show your outcomes are better. How are you going to get better outcomes? That's a whole separate discussion, but you're going to validate that through the MS disease activity test and say, all my patients on average, have a score of this or less.
And speaking of outcomes, we're getting ready to launch a prospective study looking at outcomes. And so we're in the process of identifying sites now to participate in the study.
My practice is an integrative neurology practice, and I do everything and hopefully more that the typical practicing neurologist does. But we also bring in the principles of lifestyle medicine, of functional and regenerative medicine. I work very closely with Dr. Terry Walls, who has interviewed you guys for her autoimmune MS summit. Point being, I just want to make for folks who might be listening to this, who are very interested in sort of the Walls protocol or the Charlin protocol, that this test does not necessarily, it certainly doesn't tell you what drug to put a person on. But my point is that if I'm tracking someone who's dedicating their journey with their MS to a more Walls or Charlin type of approach, the ability to see where things are going, even if you're not taking a drug, is hugely valuable.
Yeah.
Because then we can sit down and we can say either things are going exactly where they're supposed to be going. And of course, again, we use other metrics. We do 25-foot walk, peg hold test, fatigue rating scale, et cetera. But having that information can really validate the choice to not use disease modifying therapy, to add disease modifying therapy if you have started on a different journey where you're beginning with more of a functional medicine approach. Because let's be honest, we can't control everything all of the time. And everyone with MS is unique and different. And some people do extremely well on a functional medicine, lifestyle medicine type of approach, but some people need the drug. And I would only argue that the people who combine diet and lifestyle with the drug generally do way better than the people who are just using the drug. in
Yeah.
general.
Yeah.
So it's a really don't think that this is just all about medicine, all about taking a pill or injecting yourself or getting an IV. This really is about understanding where you are with your disease so that you can be in the driver's seat.
Correct.
I know we've been talking for a little while, and I really appreciate your time. I want to ask one last thing because you guys are looking at some new things, and just around the bend, it's been on your website for a while. You were granted $10 million from the Michael J. Fox Foundation to
Yeah.
develop a panel, a blood-based panel for Parkinson's disease. And I know there's probably some things you can't talk about with that, but what can we hopefully look forward to in the near future?
We're hoping the panel will be commercially available in 2026. And the focus is on progression of Parkinson's and helping guide treatment decisions and hopefully have some DMT choices someday for Parkinson's.
That is wonderful. Are there other areas of neurology that there is scientific investigative interest in within your company that you're exploring?
I think Alzheimer's is something we're exploring where that's much further down the pike, right? Parkinson's and the MS disease progression panel would be first, and then maybe down the road, Alzheimer's.
That's great. That's Jennifer Chesser. It's been such a pleasure having you on the Healthy Brain Toolbox. I know folks who've spent their time listening to this interview will have gotten tons of valuable information. If you are a provider, I would encourage you to reach out to the company, go to their website, contact them through either a web-based form or phone number. They've been hugely helpful. They will come to your office. They have field reps just like any other company. Just speaking from personal experience, take advantage of the opportunity to get on the phone on a Zoom call with someone like Jennifer to go over all your data, test every single one of your MS patients. And of course, if you have MS, I would only say seek out a practitioner doing this test because we got to be practicing 21st century medicine. And to not include a metric like this is really to be 20 years behind.
Very well said.
Thank you again, and we look forward to future conversations.
Thank you.
Hi, everyone. Dr. Ken Charlin here with the Healthy Brain Toolbox. I'd love to hear from you. If you have general questions about brain health, neurology, or the science of keeping your brain sharp, send them to questions@healthybraintoolbox.com. I'll be reading your questions on the upcoming episodes. Please remember, these need to be general questions. Can't answer personal medical questions or provide individual medical advice. So if you've ever wondered about brain health strategies, lifestyle tips, new research, or the future of neuroscience, send those questions in. I look forward to hearing from you, and who knows, you might even hear your question featured on the show. Thank you for tuning in to the Healthy Brain Toolbox podcast. I hope today's conversation gave you new insights to protect and nourish your brain. Be sure to subscribe, leave a review, and share this episode with anyone looking to take control of their health. Until next time, stay sharp and keep learning.